let's get started. Um, Welcome everybody to another great webinar from InstaRisa's. We're excited about this one, really excited about it. Jay, go ahead and next slide. What I want to walk you guys through is a few things, but we only have a few slides, which is great. Here early on presenting. Oh, there you go. Thank you, Jay. Just making sure we got the right one. All right. All right, so who are we? So I'm your host tonight. My name is Ben Merlo. If you haven't met me, I'm the CFO, COO of InstaRisa's. And we got Morgan Fisher here as well. She'll be presenting. We'll go more into her background here in a minute. Next slide, Jay. All right, so what are we doing here? The main purpose of what we do here at InstaRisa's is basically what we call taming the three-headed monster. I know Dr. Morales speaks about this a lot in his InstaRisa's course, the main All-on-X course that we perform here at InstaRisa's, but I definitely wanted to go over it real quick, just for everybody that's not familiar with InstaRisa's and what we're all about. So there's a lot of information and misinformation out there on digital technology, and the biggest thing being is that we have to create these restorations in a predictable and efficient way. And so taming a three-headed monster is a big part of what we teach. And the first part of that three-headed monster is passive fit. And you can achieve that through photogrammetry, which everybody knows, which a lot of people know about. But we also here at InstaRisa's have an alternative photogrammetry, which we've done 7,000 to 8,000 arches across all of our doctors over the last few years. And, you know, Dr. Morales has never used photogrammetry in his office. I want to be clear on that too. And yeah, we get passive fit every single time as well. But again, there's many ways to achieve passive fit these days, but that's just one component of taming the three-headed monster. The next one is aesthetics, making sure that the aesthetics are lined up, and we do that with our 3D facial scanner. And so yeah, it's a big part of what we do, and what Morgan's going to talk about here in a few minutes is how to achieve proper aesthetics. And then the last thing, which I think most people struggle with, I talk to a lot of doctors out there, and the biggest thing I think they struggle with and have mishaps on is obtaining the bite. So you got to get the bite right. And again, Morgan's going to talk a little bit about that too here today as well. Next slide, Jake. All right, so if you're not on the InstaRisa's tribe, please join. Scan this QR code now. It's free education for everybody, and it's a great community. And yeah, I recommend everybody jump on in and see what we got to offer on the tribe. And also our social media tags are in the bottom left. Join us on social media as well, please. So yeah, we'll see you there. All right, so it's my privilege to introduce Morgan Fisher. She's an amazing human being. Obviously, she's a great designer, but also a great person. So I'm blessed to call her a friend and colleague as well. So Morgan, I'm going to turn it over to you to talk a little bit about your background, and excited to hear you talk here tonight.
Hello, everybody. My name is Morgan. I'm just going to do a little bit of an introduction. We'll go over some objectives and not a lot of slide presenting today. I really feel like everything just clicks for people when they can see the alignment of all of the files and see what goes into an InstaRisa's design. You hear a lot of talk about, you don't need a facial scanner, and that can be true, but we're here to show you the benefits of a facial scanner, the benefits of our workflow, and really just overall the level of support that you will get when working with InstaRisa's with our team of designers. So a little bit about me. I currently live in Chicago. My background started in dentistry and dental hygiene. I graduated from dental hygiene school in 2019. I pretty quickly realized that, I really enjoyed dentistry, but hygiene just didn't really seem like my avenue. I was a little bored. So from there, I started picking up how to be a chairside restorative assistant. And then from there, surgical assisting. And that's where I kind of got introduced into doing all-in-4 surgeries. Started with chairside conversions, doing analog denture conversions, smart denture conversions, and then slowly kind of making things digital. From there, I started teaching myself ExoCAD. I got experience learning 3D printing, staining, glazing, milling. So my favorite thing about really just digital dentistry is I've had a little bit of experience in All-on-4 with both, and with both analog workflows and digital as well. And I like to think that at my best, I got pretty decent at doing a chairside conversion. But I'm very confident that even on my best day of doing a conversion, I can't deliver the same product that I can in a digital workflow. And the benefits are huge. It was a bad day if it was a Friday and we got a call from a patient saying, hey, my chairside conversion broke. So just to be able to plan everything preoperatively and know that we're able to execute it on the day of surgery, and we're not just depending on a pickup, and we're not entirely sure if we can deliver the product that we're wanting to deliver to the patient. So I'm going to go ahead and start presenting my screen here. I will just start off by going over, Jake, is there another slide in there of the objectives? There we go. Just a couple of things that we're going to be going over today. We're going to go over the pre-design workflow and just some communication that you will get between myself or one of the other InstaRisa designers when you are utilizing InstaRisa design services. We do prefer to use COIS principles using the facial scans, using COIS principles. We will upload all of the facial scans, and as John Coyce always says, if it looks right in the face, then it's right. So I'll just show you guys a little bit of where I get started by setting all of my landmarks, and then treatment planning based on the patient's individual aesthetic and functional risk. So a lot of times once the patient is digitized and all of the files are aligned, I will communicate back and forth with the doctors because it's a lot different when you're looking at a digitized patient. You have the CBCT overlaid with the facial scans and the intraoral scans. And just being able to look through all of those scans and really decide the best course of action for the patient. Maybe it is a younger patient and we're going more towards because they are at a high aesthetic risk due to extreme lip mobility. Maybe we are looking at more of an FP1 case or crown and bridge case where we can. So a lot of my day-to-day is just kind of also working with the doctors and seeing what we feel like the best treatment plan for the patient is going to be based off of their function and aesthetic risk. And also going over surgical execution. So anytime a pre-design is done through InstaRisa, 9 times out of 10, unless it's just a home run case aesthetically, you're going to get a note attached to your HTML viewer. Every InstaRisa pre-design will come with an HTML viewer in which you can open with exocad Web Viewer. It's a free app on your phone. You'll be able to just flip through all of the meshes and kind of see what we have pre-designed there. And almost every design is going to come with a little note, saying any concerns that the designer has that we need to be aware of on the day of surgery. So if we're looking at a patient that has high lip mobility, you'll get a note on that design saying, hey, from the incisal edge of number 8, I'm measuring 12 millimeters. We need to do 12 millimeters of bone reduction to make sure that we're hiding that transition line. Just anything that's popping out at us. If we feel like once the bone reduction's done, the mandible's starting to get a little bit wider in the posterior, we will be in communication with that as well. We might be looking at a crossbite here. Maybe this patient's better for crown and bridge, just based on different aesthetic risk. And then on the day of surgery, I'll just kind of flip through what a day of surgery conversion would look like after the pre-design is done, what the communication would look like, and just going over doctor preferences. At InstaRisa, like I said, we prefer COIS principles and occlusal schemes, but if you prefer something different, we really like to cater the designs to each individual doctor and see and go from there. So Jake, I think from there, I'm going to go ahead and present my screen. So before I get started with the CAD scene, I'm going to go ahead and just show a quick little video. This is one of my favorite things about using the InstaRisa facial scanner. A lot of people are kind of unaware of this functionality of the facial scanner. To my knowledge, no other facial scanner on the market can do this right here. You'll hear people say that we can use this facial scanner as a bite scanner. So this is just some alignment here. This patient is fully dentate, so this is a good example. But my favorite thing about the InstaRisa scanner is that with patients that do have collapsed verticals, we are looking at a challenging bite to scan with an iOS. We can scan it with our intraoral scanner here. So on the left here, we have our intraoral scans, and on the right, we have a facially scanned bite. And this is just kind of showing within the exocad software how we can align the bite based off of the facial scans. So we're just aligning our upper iOS scan here. In exocad, we're looking for camouflage here. You saw a lot of blue in that mesh. A blue is an exact one-to-one mesh. And I know that that means that my files are lining up properly. So here, instead of mounting this bite off of the intraoral scan bite from your Trios or your Prime scan, it looks like here in this instance, this bite was opened a couple millimeters, which is great, because anytime we're opening a bite with an intraoral scan, it can be extremely challenging if you're opening the bite more than just a couple millimeters. So overall, especially in all-on-X patients that we are that have collapsed verticals, to be able to set the bite with your extraoral scanner is a huge win for us, and I'll kind of show a little bit of what that will look like. So just to start off with this patient here, this is just a pre-design that I did today, actually. The doctor originally planned for upper lower all on 4, and then due to the patient's age, we kind of discussed back and forth. He decided that he wanted to proceed with crown and bridge on the lower arch. So I'm just going to kind of flip through my meshes here and go through what that looks like and how I get started. So when you receive an intraoral or an InstaRisa aligned case, a lot of times the files will look like this. So I know that we have a couple designers on the chat, a couple lab technicians on the chat. So a service that InstaRisa does provide is we provide AI alignment. So when you're working with full arch, it can get a little bit overwhelming. Even for the most experienced exocad users, it can get a little bit overwhelming because there's just a lot of meshes going on. And to align them all can take quite a bit of time. We are really proud that we've been developing our AI system, that we're able to provide this service for you guys, where you can send us all over your files, and we can send you back a CAD scene that would pop in just like this, all of your meshes aligned with your intraoral scan, with your putty bite scan, and it will also already be articulated within the virtual articulator. Another thing that I don't think that we mentioned earlier, if anyone has any questions, this is very much open format, so you can just raise your hand in the chat, or you can type the question in the chat. Very much open format here, so if you're seeing anything that you have questions about, or anything that maybe I'm flipping through too quickly, just shout out or raise your hand here. So before we start here, I always just like to check my alignment on the articulator. I won't get too much into the weeds of exocad here. Overall, I'm just trying to show you guys how I get to the finished product. So like I said, everything will be aligned within the articulator here. Another great part about using facial scans is that I'm a lot more confident when I am using my virtual articulator versus if I don't have facial scans and I'm just working off of the iOS scans and the 2D photos or no 2D photos, because now that I know, a lot of times the pre-ops that we're getting are extremely canted, overclosed. If I can mount the patient in the articulator using my facial scans, I can see where the hinge axis is at. I can look at different angles. I can look at their profile from different angles, make sure it's not tilted too far. This gives me a lot more confidence when I'm opening and closing the bite virtually. Because, you know, a lot of times if the patient's full dentate and we feel like, you know, maybe they need to be closed 2 millimeters for aesthetic concerns, we're not going to expect the doctor to, you know, hack down everything 2 millimeters with a handpiece. So what we can do here is we can just open and close the bite with the virtual articulator. And I'm a lot more confident using the virtual articulator, knowing that it's not going to mess up my bite because I'm mounting everything off of the facial scans here. So, and this is another just kind of level of communication that you will have with the designer. If maybe on the day of surgery you weren't able to do enough, you know, maybe as much bone reduction as you were hoping, we're still kind of searching for some restorative space. We can open the bite virtually, that's no problem. And then also just preoperatively, when I'm looking at these scans, I'm checking the patient's side profile and making sure that I feel like their side profile is adequate enough and we don't need to open the vertical anymore. So this patient looks good. I believe she was opened preoperatively. It looks like this case is from Dr. Dodrell, by the way, Dr. Dave Dodrell in Montana. I love working with his team. They're great. So he has a ton of experience going to InstaRisa courses and opening bites. So it looks like here he took a putty bite and he opened just a couple millimeters, and I'll show you guys what that alignment looks like. So patient's currently wearing a full upper denture and has most of their teeth on the lower. Looks like we're dealing with an upper denture cant here. I can turn on my smiles to see what I'm looking at. Without an intraoral scan or even a 2D photo here, what are you getting in the analog world here? When this is being mounted chair side, it's going to be mounted about like so, right? Because we don't know what it looks like in the face. But because I'm able to mount everything on my articulator based off of the face, I can see that this patient has a cant. So just starting off here, Dr. Dave opened the bite with the putty bite, like I said. I can turn on the full mush bite here and see camouflage on the underside right here. This is a really good putty bite. And I can see camouflage on the top side as well. So everything is going to align well. He opened a couple millimeters from some restorative space. We love that, especially when doing crown and bridge. We pretty traditionally like to open 1 to 2 millimeters on any crown and bridge case, because essentially that means we get to prep a little bit less. And he also took a 360 scan of the patient's upper denture with a really nice denture wash, so that on the day of surgery, I can see all of this nice tissue references. I can see the rugae here. I can see, the maxillary tuberosities, so that I know when on the day of surgery, I will have good soft tissue alignment after he places his fiducial markers. So like I said, the game plan here is going to be upper all on 4 and lower crown and bridge. So just going back and forth a little bit about the Coyce principles, what we're looking for here. I always start off after everything's articulated. I start off with my repose smile here. This is the patient in the most relaxed position, and we always set our incisal edge position off of repose. According to Coyce principles, we like to see about 1 millimeter to 2 millimeters in repose here. So I'm going to go ahead and set my incisal edge position here. I already decided the midline based off of when the patient was being articulated. So we decided on the midline here. And then if I zoom in, I am going to lengthen her incisal edge position. All of these grid lines in the back are about 1 millimeter. So we're going to lengthen it about 1 millimeter here, so that I can see 1 to 2 millimeters in repose. In the sides here, it's going to be a little bit higher, but I also know that she's wearing an upper denture. When I look at the side profile, I can tell that she has a lot of lip support here. And I know that a lot of that's coming from this denture flange, especially since we washed it. So I know that once this patient isn't wearing a denture anymore, that lip support's going to come down and in a little bit. So I believe without the lip support, we'll be right at 0, which is fine according to Coyce principles here. Another thing I'm checking after I set my midline position and my incisal edge position, is just bone reduction. So I'm turning on my Duchenne smile here. This is the most exaggerated smile. This is where we really want to see the patient's lip mobility to make sure that we're communicating with the surgeon so that on the day of surgery, we're doing enough bone reduction so that we are hiding that transition line. So ideally, in measurement, we like to see about 3 millimeters, about 2 to 3 millimeters above the upper lip position in repose, which that looks like she is already there. I can make her Duchenne smile here transparent. And like I said, these grid lines are a millimeter a piece. So I'm seeing about 2 to 3 millimeters, even in Duchenne. I'm sure he's going to go ahead and level the bone out. Dr. Dodgell's an amazing surgeon. I'm sure he's going to go ahead and level that bone out anyways, so that it's flat with the posterior. But as far as hiding transition line, she's not at a high aesthetic risk for that. If she were, we would be seeing that communication back with the doctor as far as measurements go, as far as how much to reduce. And then lower is going to be crown and bridge, so we don't need to worry about any reduction there. So I decided on my incisal edge position. Another thing I'm looking at here with my incisal edge position is when the patient is in Duchenne in this high smile line, I'm not seeing a gummy smile. If she was smiling and we were seeing, 2 to 3 millimeters above the zenith of the tooth there, maybe I would raise my incisal edge position. So everything is just constantly balancing these things. Sometimes we don't have 1 to 2 millimeters of incisal show at rest because I would rather not have a gummy smile. So we're just kind of balancing these things. Everybody's face is different. Everybody's lip mobility is different. In this instance, it looks like her incisal edge being at 1 to 2 millimeters aligns really well with her Duchenne smile. She's not showing a lot of gums on the upper. And then lastly, I'm going to use my natural smile here to kind of guide my curve of Spee. So I just want to naturally follow that lower lip line to get my curve of Spee here. Let me turn on all of the teeth that I have set. Just one second here. So this is kind of where I set up the teeth. These grid lines that say InstaRisa on them, all of these are set in golden proportion. They're scalable to the patient's face. So I'm seeing it right on the outside of her nose here. I'm looking, making sure that we're kind of at inner canthus of the eye on both sides, and it's fitting her face. There's no tilt here. So because this case is going to be lower crown and bridge, I'm a little bit set on, I don't have a lot of leeway as far as curve of Spee goes. Because we're putting crowns on the lower. So this is what I have waxed up. Dr. Dodgell requested for the day of surgery that he receives a lower mock-up of this. So he will receive this model. He's going to do a putty matrix on the lower, and we'll do upper AOX with same-day delivery. Another thing that I'm looking for here, so there's just kind of like about 10 different steps that I go through when I'm looking for a smile design. Like I said, first and foremost, we're starting with the midline. Another thing I'm looking at is just to make sure that everything is aligned properly. When I'm turning these lines on, I like to look at it from the top here and see this line right here, just going right down that incisive papilla through that mid-palatal suture. And that's not always going to be anatomically correct, but it does tell me in this case, it looks like it's right on. So I'm very confident in having our incisal edge position set here. Luckily, it's also going right through 24 and 25. So I think we'll be able to achieve really nice aesthetics with that. So yeah, step number 1, always starting with the midline. Step number 2 is always going to your smile curve. So let me turn the teeth on fully here. So smile curve, like I said, we're just going naturally with this, with the curve of Spee is going to go naturally with the lower lip line. So we have that set there as well. These guidelines are nice because they can guide us with the curve of Spee as well. So once I have 8 and 9 set right here, I'm just making sure that in the background lines, all of my other, my canines are also following these grid lines in the back. Next thing I'm looking at is my interdental proportions. That's step number 3. So we're going to use golden ratio for the most part on these patients unless otherwise requested by the doctor. So these are my golden proportion grid lines here. And then the next is we're always setting our central incisor position. So I always like what Dr. Morales says. He likes the central incisors to be like twins. They should look exactly alike. His lateral incisors are going to look a little bit more like sisters, and then the canines maybe more like cousins. So 8 and 9 are always going to be exactly the same, and I can follow that while using my lines here. So just looking at some of these, I have 8 and 9 set. My grid lines are going to follow according to Quay's principles. We like our laterals to be about 1 millimeter higher than 8 and 9, and then we want the canines to be 1 millimeter higher or equal to 8 and 9. In this instance, I had to make them 1 millimeter higher because the lower is crown and bridge, and I was kind of struggling for space there. And then we're just looking at the next step, gingival curve. So here we're looking at our free gingival margin. I don't want to go above these lines here due to my gingival proportions, and then my papilla curve as well. So these grid lines here are just making sure that nothing looks too out of proportion. I can kind of show you what that would look like here for a second. So just making sure that, you know, we're not getting extremely sharp incisive papilla here. So these grid lines, like I said, all of your HTML viewers will have these grid lines on them, making sure that we're staying within that curvature. So that was papilla curve. Next, I look at a 12 o'clock analysis. So here I'm essentially just making sure that all of the teeth are over to the arch form. Everything's sticking to the arch form. It was starting on this patient to get a little bit wider due to doing crown and bridge on the lower. I don't believe that we'll need to go into a posterior crossbite, but I did communicate that with the doctor on the script here. So if we need to go into a posterior crossbite, we can, no big deal. And I did keep second molars on this prosthetic just because Dr. Dodrell does pretty frequently place pterygoid implants, and we're not occluding with anything on the lower anyways. So after I do my 12 o'clock analysis, next I'm going to look at my occlusal analysis. With an InstaRisa's design, we prefer lingualized occlusion, bilateral simultaneous contact with lingualized occlusion with 7 through 10 out of contact and no contact on the last molar. On the day of surgery, you can expect no cantilevers. On your final prosthetic, you can expect no cantilevers longer than 10 millimeters. And the reason that we really like, especially on the day of surgery, for 7 through 10 to be out of contact is so that if the bite was off and we start to equilibrate the patient in over their healing period, if we start off with 7 through 10 out of contact, once we're equilibrating them in to that position, by the time we're finished, we'll probably have light occlusion on 7 through 10 there. And then next step number 9, I always like to just check the buccal facial proportion here. So and also keep it in line with the pre-op. I knew that she had a lot of lip support, and I'm okay to bring that in. I need to bring it in anyways over the ridge, because this would be way too much of a flange if I left the incisal facial portion where it was. That's going to be too much of a flange here and create a kind of a shelfy prosthetic. So I'm just looking at the buccal proportion. We can turn on the patient smile, see where we're at here. This is great in the healed phase to make sure that lip proportions are good, and we don't need to be pushing anything out or pulling anything in. On the day of surgery, of course, a lot of things are moving and changing. So it's a really great guesstimate at this point. But yeah, just making sure that the lip support looks good. I think we're going to be good to bring her in a couple millimeters. And then, yeah, looking at the occlusal plane from the side profile as well. So just making sure that we have nice curvature upwards, going upwards into nice curve of speed into back into the ear there. So that's a lot that goes into the proper pre-op design. Like I said, he'll be doing a putty matrix on this patient. So I just virtually extracted all of the lower teeth here. Preoperatively, that's what it looks like. Once I take it away, it's going to look like so. And then this is where I have my wax up for my teeth. We have a couple of edentulous areas, so we'll be bridging those or placing lower implants in the future. And then another grid line that we have here is the curve of Monson, just to make sure that all of the occlusal, all of our cusps are occluding through this. Let's see if I can get it all on at the same time. Perfect. So this is just taking into consideration the curve of Wilson and the curve of Spee in the same plane, making sure that everything's functional. And when I'm turning this off, my lower buccal cusps aren't too high, in appreciation to the curve of Wilson there. And like I said, upper lingualized contact. So we're looking for lingualized occlusion on the upper with that central fossa occlusion on the lower. So then I'm gonna go ahead and flip to the next patient, just one more patient here. This is a day of surgery. This pre-design was actually not done by myself. It was done by one of our amazing designers, Peter. I did the surgical conversion yesterday though, so just kind of wanted to walk through the workflow on the pre-design here. So let me turn on what that would have looked like preoperatively. One second. So the doctor would have received, we opened with a pre-op mush bite as well. In this case, we aligned everything to the face with retractors. We see nice, good camouflage there. This is the patient in Duchenne. Looks like we have a really big smile line here. Another note, just when you're taking these facial scans, if you are taking a putty bite or a mush bite, you really want the lip positions to be in the position that, the ideal position. So like here, it looks like the putty bite might have gotten a little thick. We're getting curvature here in the lip. So I know that this preoperative lip position is probably a lot thicker than what it's actually going to be without the putty. So we just want to make sure that we're trimming these things back and all of our lip positions are exactly where they're going to be. So I have a better idea of where to wax everything up. So this is the patient in Duchenne. We have the lines going through the face. There's our anatomic wax up. Peter did a great job on this. And so on the day of surgery, we have our pre-op. They sent over records for the upper pre-op with Scandar. So it's going to look like this. Then they sent the Scandar. From that, I can grab my implant marker position right here. And then from there, I have my upper tissue. Same thing on the lower. My lower, we have a fiducial marker placed right into the mentalis area. Alignment looks really good. And then we have our lower Scandar. That's where I'm going to get my implant position. And then we have our lower tissue. So the nice thing about this is these implants were placed super subgingivally. So we were able to get really nice emergence profiles here. This was done with TRI implants. So I believe, no, just kidding. This was done with, I was thinking of another case. This was done with a normal multi-unit. So we have nice subgingival structures here with ovate ponics. Peter had communicated the ponic workflow, exactly what the doctor wanted, with tissue pressure as well. So another thing that we just like to communicate back and forth with the doctors is desired tissue pressure. You know, some people don't want any tissue pressure at all on the day of surgery, and then other people like a lot. General rule of thumb, if you are receiving a surgical design from InstaRisa, unless otherwise requested, for tissue intimacy on the day of surgery, you can expect about 1 millimeter to 1.5 millimeters of pressure on a traditional FP3. And then once healed, we're looking at 0.5 to 0.8 millimeters worth of tissue pressure there. Another thing that's just great is just showing the patients these preoperative scans here. I believe that this patient was actually originally planned for a FP3, and then upon the pre-design, there was communication that, due to this patient's extreme lip mobility, let's go back and maybe consider doing an FP2 or FP1 for this patient. So there was communication back and forth. We decided to not do an FP3. We did an FP1, which it looks like what was a great idea due to patient's lip mobility. We weren't able to take off that much bone. So that's just a little bit of an example of what I was talking about in terms of, the communication with our designers, going back and forth, and what you can expect from an InstaRisa design. Again, all of our designers have chairside clinical experience. They're not all. I think I'm the only hygienist, but everyone else has assisting experience. Everyone's very familiar with the workflow, very great with problem solving, helping you guys with any issues that you might have, the best way to set the bite. Very, very well versed in occlusal schemes. Like I said, if you don't prefer lingualized occlusion, we create custom doctor profiles for every doctor that we work with. We have group chats with every doctor that we work with. So we know your preferences. We know what screw you prefer. If you like same day delivery versus next day delivery, tissue pressure, aesthetics, tooth shape. And we really try to keep each designer with the same doctor so that we can establish that relationship, and we can really cater the designs to what you guys like. So I think overall, I pretty much hit on everything. I don't know if anyone has any questions. If Dr. Morales or Fernando, Dave, Ben, if there's anything that I left out.
Yeah. Thank you, Morgan. That was an excellent presentation. Appreciate it. Yeah, I do want to open it up to questions right now. I know Dr. Morales is on this call as well. I'm sure he wants to chime in here in a couple minutes, but if there's any questions on what Morgan just presented, I'm going to go over a couple slides here in a second, but I definitely want to answer questions if there are any. And feel free to either, again, raise your hand or just ask the question. You can unmute yourself too.
Yeah, hi Morgan, this is Dr. Kumar from Chicago.
Yeah. Hey, Dr. Kumar.
There's an echo there. I'm sorry, I'm not sure where it's coming from, but it was very fascinating. This is kind of my first introduction to everything you guys do. From a provider standpoint, it seems very complicated, but I understand that what you just presented is what you do on the back end of things to allow us to deliver a fantastic result. I think you're about to show us what we have to do as providers and what we have to give you in order to do all this magic on the back end, correct?
Yeah, that would be the next step for sure. But yeah, I mean, it really, what I'm about to show you too, Doc, is that it's really about the intake records too on your end, and just following the recipe, following the steps, and once you do that, our designers like Morgan, we'll be able to put the pieces together for you as well, and tell you where you're off as well, which is a big part of it, is that the communication back to you saying, hey, this is wasn't scanned properly, or you got an issue with the bite because the bite wasn't taken properly, things like that. So I think it's a big thing, is to obviously train you how to do the intake records properly, and then once that's submitted, we're able to give you the feedback necessary.
Great, thank you.
Great question though, thank you. Yeah, and we'll go through the steps right now. Any other questions though? I know there's a hand up. The name's Z Sam.
Maybe it was an accidental hand raising.
Yeah, it's all good. All right. So yeah, let's go into how you get started. And Art, unless you want to say something first before we get into this.
Yeah, excellent presentation, Morgan. I think it really highlights the difference between um, most workflows and specifically the InstaRisa workflow. Um, what it really comes down to is the records. And we just had a case literally just yesterday that was sent to us on an emergency. And when the restoration was delivered, the doctor mentioned that the bite was off. And what we sent back was literally a 5-minute um, screen view of why the bite was off. It had nothing to do with, um, the workflow. And it wasn't even an InstaRisa workflow, by the way. It was literally, they just sent us uh, upper arch, lower arch, and some scan body positions. And the reply that we sent back was a 5-minute video that explained why the bite was off to begin with. It had nothing to do with the workflow per se. It had everything to do with the the records that were taken at intake records. Because as Morgan shared, the ideal workflow is that those records are sent to us so that we can design the restoration prior to surgery. That gives us an opportunity to recognize if there was a bite issue, as was the case with this example I'm giving you. You can still rectify that. You can still correct it on the day of surgery by taking a new bite record. So by sending us the records in advance, it allows us to really minimize the risk of problems that are not discovered until you deliver the restoration. If you're just sending us the records and saying, hey, I need a design done right now for this surgery, it's a little challenging. But the point is that we're not just a design service. We're not just designing. We're also educating. We're also training, and we're providing constructive feedback to help the case go smoothly. And why do we do this? Because I'm a clinician, right? In my practice, we do 15 to 20 arches a month. And it's very, very, very important that we minimize the amount of visits for those cases. Because if I'm just, let's just say on the low end, I'm doing 10 arches a month. And if I have to do 3 try-ins for those 10 arches, that's 30 extra appointments, or let's just say 20 extra appointments. Where do I put those patients? And those are all zero production appointments. So for me, it's vitally important that we minimize the amount of visits, the amount of try-ins, because they're very, very costly. And so the goal with InstaRisa is to minimize the risk by improving the predictability by having this exchange with the clinicians. But yes, the intake records is essential. And so and really the facial scan, it takes literally 30 to 45 seconds to scan the face. And so it doesn't add a significant amount of time on the front end. And so it really comes down to is, do you want to spend extra time on the front end so that you can go fast on the back end? Or do you prefer to just struggle along throughout the entire case and really lose the confidence that patients tend to lose in us when things don't go smoothly? So, but nonetheless, Morgan, phenomenal job. Thank you so much. You're an amazing designer, an amazing person, and I'm so proud of all that you've accomplished and all that you're doing. Thank you.
Thanks, Doc. Was there
All right.
any?
Yeah. Any questions? Yeah.
Yeah, sorry, I got kicked out earlier. I have a question about the facial scanner and what's the proper way for the patient, standing, sitting, and the scanner should be eye level.
Yeah, we prefer the patient to be sitting, mainly because we don't want them to be moving. You'll start to see if there's movement, just same with an iOS, anytime there's movement, you start to see some scan distortion. So we prefer for the patient to be sitting. It can be in a patient chair. Treatment chair is a little bit harder to lean over the patient. Fernando, can you mute yourself, please? Because you have to lean over the patient. A lot of people just put them in like a regular chair that they have from, say, the waiting room. But yeah, we prefer them to be sitting. Did that answer your question?
Yeah, currently my setup, I have a bar stool and I always have issue positioning them to face. They're always punching in. So I just need to find a different place to set it up.
Yeah, a lot of times that is one reason why I like a patient chair, clinical chair, is because it has a headrest. Because especially when you're setting the bite, if there's something in their mouth, plus the retractors, they tend to they want to lean back or they want to lean forward if they're in like a bar stool type chair. But something with a headrest is really nice. That way they can rest their head and then we have less movement. Any other questions?
A quick shout out to Fernando Blanco. It's his birthday today. Everybody, if those of you don't know Fernando, he's the co-founder of InstaRisa. He helped develop the whole workflow, and they call him the wizard because he designs like a wizard within exocad as well. So Fernando, anything else to add on your end? Happy birthday.
Happy birthday, Fernando.
Thank you. No, like, great presentation, Morgan. She said something that it's key, to get really good results, and communicate back to the doctor to based on, what we see, right? Like our designers, we have a clinical background, right? That's very important as a designer because, we spend time, in the chair seeing surgery. We can see everything, right? That's huge for us because we're able to communicate back to the doctor if we see something that looks off, or if we want to feel like, if we see like, hey, we need to open the bite here, we communicate to the doctor. If we need to cut the bone, right, we communicate to the doctor. That's the key, for the success of these cases. Having that clinical background, it helps us to see things that if I'm just a designer just behind a computer without clinical background, then I'm basically, I'm not going to be able to communicate back properly to the doctor and help the doctor to, execute this case properly. So that's huge for us. And that's something that, all of us can provide to all our doctors.
Thanks, Fernando. Happy birthday.
Awesome. Any more questions before I keep going a little bit deeper here? All right, so where do I start? Ideally, we would love for you guys to come out to an InstaRisa course, right? That's the number one, is attend an InstaRisa course. You're gonna get dialed in with all kinds of educational pearls from Dr. Art Morales, who just spoke earlier. He really dives in deep on the clinical side, and there's so much information there. And we don't just cover all X, by the way. We cover anything in the aesthetic zone. We design dentures, overdentures, crown and bridge cases, veneers. So yeah, we go over many workflows. We go over the technology. We go over how to take intake records, and we even dive into practice growth and marketing. How to do more all X. We usually have good speakers talk about that as well, and some ideas to help you guys grow your practice. So the courses are always great. You go to InstaRisa.com, and or you can just contact me. I'll give you my contact information at the end here. And yeah, we got a couple courses coming up this summer that are awesome. And again, I'll go over those with you as well. Yeah, so another way, a lot of the times it's not ideal for doctors to join us at courses. So we could come to you. So we have implementation that we come to you and say, hey, I got a case coming up and I need some help. And so, yeah, again, same thing. Give me a call. We could come to you. So Fernando and Morgan are our two main implementation specialists. So they come out to you guys and do a case with you. Again, train your team how to do accurate records is a big part of it. They'll go from intake records to chairside surgical records, even to the point where once the design is finished, they'll help you standing glaze. They'll print it, standing glaze, finish it, characterize it, and place it temporary. So I think it's if you guys are developing teams and you're trying to get to the next level, having an implementation specialist at your practice will definitely help. All right, so those are the top two. So then you say, okay, what if I don't have an InstaRisa facial scanner? So what we're doing recently is, as Dr. Morales just mentioned a few moments ago, is we are taking on cases that don't have facial scanners. Now, we do throw caution in the wind, of course, on this, but we want to definitely help people get better records, and we're doing everything we can to assist with that, right? So so we're accepting 2D photos along with photogrammetry or other methods to capture implant position. And again, we can walk you through those cases as well. But again, I want to make sure I highlight this is proceed with caution. So we have a higher probability of discrepancies in aesthetics and bite. So remember, the three-headed monster I spoke to about earlier, getting the implant position is one thing, guys. I mean, photogrammetry is a great tool, but it doesn't allow you to get the aesthetics right and doesn't allow you to get the bite right. So the way we combat that at InstaRisa's, as you guys all know, is we have a facial scanner that scans at a 40 micron level that really helps us get that dialed in. But again, without it, there's some guesswork that Fernando and Morgan are amazing designers, and they could guess sometimes and they can get it right. Other times it's not so easy. So anyway, we can do it for you guys if you don't have a facial scanner. We definitely want to try with you. So if you want to, if you're interested in doing that, please contact me as well. And I want to make another point on that too before I go to the next point, is that the first revision is free. If there is a problem or there is a discrepancy, and what I want to do is make sure I communicate that more than likely there will be, but if there's more that we have to go more revisions, obviously there will be extra fees, and that's kind of how the labs work, and that's how our design services work as well. All right, so the next thing I want to discuss is we do have our surgical components as an alternative to photogrammetry. So again, if you're not interested in obtaining a facial scanner from us, you can buy our components and use that as an alternative to photogrammetry. We believe it's the best value system out there in terms of you're able to get a passive fit, and you're able to get them at a lower price compared. You don't have to spend $30,000-$40,000 for a photogrammetry unit. We can show you how to do that. And the components that you purchase from us, they're made out of titanium, and you can use them over and over again. So that's another added benefit. So next point here, Jake. So the price for the starter components is $3,448, and again, it's reusable. A lot of the components are reusable. It comes with an artificial reference screw, which is our fiducial marker. And that I'll be able to break that down further for you guys if you want to understand what's all included in that pack. So again, reach out to me if you have any questions about the starter pack as well. So the price for our all-next services, which I want to go over real quick. I mean, we just went through this whole presentation. I'm sure a lot of you guys want to understand what our prices are. So our normal price for an arch is it's fully designed at $875, and what that is, what you get for that is you get a pre-design, which again, intake records. You send it up to our portal. We do the design. We send it back to you, doc, and say, hey, did you like this design? And you say yes, you approve it. You have the option then, doc, to show your patient, within the 3D smile and the 3D format. And there's ways we can show you how to do that on your smartphone even too, once you get there. And then what also includes the next phase, which is the surgical conversion. So when you go to surgery, we're able to get you a design back same day. So you can be able to want to do same day delivery or next day delivery. We have that option. And then the last part of that of the phase is, well, there's two more phases, is a prototype. So we do a prototype. If you want to make any changes on the temporary, we can do a prototype design, and then we do a final design. So really there's 4 phases to go through there. So you got pre-design, surgical conversion, prototype, and final design. So I want to make sure we cover all that all. And yeah, so that's the next point. Is that it, Jake? Is that the last point? All right, great. Any questions on that slide? I want to make sure you guys got it all. We want to thank everybody for joining us tonight for the webinar. This picture it's a great way to end this webinar. It's a picture of Dr. Lane Harris. He was out here for a course, and Morgan actually took a shot of this picture. It's one of her best pictures, she said, she's ever taken. So wanted to kind of end the webinar in a jovial way. And so yeah, this is how he feels after we send him his designs every day. So yeah, any questions? Again, here's my contact information, everybody.